presenter, Dr. Brody. So let me tell you a little bit about Dr. Brody. He is the Associate Professor of Nursing and Medicine at New York University. He's Associate Director of the Hartford Institute for Geriatric Nursing and founder of Alleviato. His work focuses on the intersection of geriatrics, palliative care, and equity. And he tries to do that work by seeking to improve quality of care for older adults with serious illness. He's the PI of two. One would be hard enough, but he's the PI of two NIH-funded large-scale pragmatic clinical trials, one that focuses on improving care quality, quality of life, and healthcare utilization for people with dementia in receiving home health care, and the other for people living with dementia who are receiving hospice care. The primary outcome of that study is to reduce inappropriate antipsychotic use that might lead to reduced function and quality of life. Dr. Brody is also passionate about mentoring and has developed and led and leads the Hospice and Palliative Nurses Association Leadership Development Program. He's a remarkable member of our scientific field and is also a member of our PCRC steering committee, and we're very delighted to have him present to us today. Thank you, Dr. Brody.
Thank you, and it's an honor to be here with all of you today and share a little bit that I've learned about conducting palliative care trials in persons living with dementia and their caregivers. I'd be remiss if I didn't talk about some of the amazing leaders in our field who have paved the way for others like myself to move this forward. And my apologies, you're going to hear sirens throughout as we are right next to Bellevue Hospital's emergency room. Including Laura Hansen and Susan Mitchell, some great work by Joan Tino, and the whole many of the individuals involved in both the PCRC and the Impact Collaboratory, as well as, of course, Christine, who's on the phone with us as well, and the leader of one of the leaders of the PCRC. So, you know, it takes a lot of people's shoulders to build off of and grow with. So I'm grateful to a whole host of people. I'd also like to acknowledge the PCRC and our support of the PCRC, NIA support of the two trials I'm running, a stage 3, stage 4 hybrid efficacy effectiveness trial and a fully pragmatic trial in hospice, as well as the Impact Collaboratory, which is just started in September through a large cooperative agreement with the NIA to help develop pragmatic trials capacity for persons living with dementia and their caregivers in embedded healthcare systems. And so Vince Moore and Susan Mitchell are the principal investigators of that. I am going to share that all opinions are mine and mine alone and do not represent the opinions of the PCRC, Impact Collaboratory, or NIH, and please do not misconstrue them as such. And before we get going, I'm sure that many of you come with your own questions about clinical trials in this population. And so if people wouldn't mind sharing in that little Q&A box, if you are on the phone, what do you want to know about? What do you hope to get out of today? So I'm going to give people a minute just to type in, call them questions or thoughts or what have you on design and conduct of palliative care trials in persons living with dementia and their caregivers. So as those questions come in, through the chat or the Q&A, either one. I'm going to share a couple of key decision points that I felt were important to discuss, and some will very much echo what are in the questions that are being asked. So some of the key decision points that we're going to talk about in the next 50 minutes or so, give or take, are who our subjects should be, whether we should be including persons living with dementia, care partners, dyads. You could throw clinicians into that mix as well. Severity and type of ADRD and how do we measure that? Outcome measures and how do we think about outcome measures? Inclusion and exclusion criteria and focusing on more or less pragmatic nature. Protocol and research procedure flexibility. And all of those things affect our recruitment and what I should say is our retention process as well. And so those are all things that we're going to focus on, whether it's regardless of who our subjects are. And so that looks like that covers a fair number of the questions that have been submitted so far. And then we can also talk a little bit, it looks like there's some questions about piloting, and we can talk a little bit about that at the end. So the first issue is around subjects. And the real question is, who do we want to, how do we focus on, and which subjects are we including? How do we want to tailor towards them? And so when we think of the person living with dementia, the pros are that we're getting patient experience, whether that's through observation or information, depending on where they are within their disease trajectory. And some of the trickiness relates to capacity, consent, and assent, and we're going to come back to that piece, as well as willingness and the reliability of the data that we collect from this population. In terms of care partners, we have some pros in terms of they can often better describe the behavioral symptoms and other care concerns. But on the flip side, they are often overwhelmed. They may not reliably report some of those issues. Which care partner are we choosing? Are we focusing on informal or formal care partners? So there are a substantial number of questions about who and how we choose care partners. And then we have the dyad. And so if we think about the dyad, we get a more complete picture when we use the dyad versus just the person living with dementia or the care partner. But it's harder to recruit, and it comes back to who we're including, who is the care partner as well. And so all of these things both all filter in both into our measurement issues, our design issues, and our recruitment and retention issues. And so this is the way that I'm framing it, and we're going to go further into this as we get into recruitment and retention. But a lot of this comes back to what our study goals are and who we're trying to really impact upon within our clinical trial. And so we need to think very intently and have a lot of intentionality about this, because each of these different items, and you could include caregiver clinicians as well in this list as a separate group, bring different pros to the table, but also have different challenges that come along with them. And so when we start to think of who we are including, one of the most important things to think about is the severity and the type of dementia. And so when we are in palliative care world, if we're stepping outside the geriatrics world, a lot of the times within palliative care, there is no formal diagnosis in just general practice in general of what type of dementia someone has. But there are substantial differences between the types of dementia, and they do affect the care that can be provided as well as the symptoms that are presented with. And so it's really important as we think about this, how do we consider, are we just including all types of Alzheimer's disease and related disorders? Are we considering only specific ones? So for instance, the problems that might occur in frontotemporal dementia, which tends to occur much earlier on in a person's lifespan and has substantial issues around executive function and impulsivity because it affects their frontal lobe as well as language centers. Those patients' symptoms may look very different than someone with dementia with Lewy bodies or Parkinson's dementia, who is going to have movement symptoms, a substantial number of hallucinations. And so we really need to think about, do we care about the type of dementia? Are we lumping everyone together? If we are, what are the unintended side effects for that? And how do we have to tailor our interventions towards broader or narrower focuses? And this goes both if you're thinking about the person living with dementia, as well as the caregiver, because when you think about the caregiving that's being provided, caregiving that's provided to someone with Parkinson's disease and dementia is going to have some very different facets to it than frontotemporal, for instance, or than Alzheimer's disease. Alzheimer's disease, about 10% of patients have hallucinations. They don't have all the movement symptoms of Parkinson's and dementia with Lewy body, and much greater, wandering risks. So the challenges become different around the symptoms that occur. And so we really do have to think about who and what we're trying to conquer. And what goes along with this is the severity and severity of the dementia as well. And so, when we think about dementia and we think about serious illness care as a whole, we've started to move much more upstream. And so the question is, where does palliative care now intervene? And I'm going to use palliative care broadly because this could be a primary palliative care intervention, a secondary palliative care intervention. It could be intervening with primary care providers or nurses or case managers or social workers. But the key is that we're moving upstream in care of persons living with dementia as well. And there are a lot of things that can be done early on in this mild cognitive impairment, which is not dementia, by the way, or mild dementia stage that you might not be able to do in the more severe stages where there are greater symptoms, but less opportunity to capture patient wishes and do effective advanced care planning or narrative medicine or other sorts of interventions that require people to have higher cognitive function. And so we really need to think this through as to where within the stage, or are we opening this up to all? In which case we have to think through what the implications of that are, because each stage has different ways that their disease is going to be experienced, both from the person living with dementia and from caregivers' perspectives, and therefore our measures might change as well. I would argue here that unless you are, that mild cognitive impairment, while not dementia, until it moves into mild dementia, mild cognitive impairment is not itself dementia. About 50% of patients do move on to having dementia, and especially if we look at our oldest old, that number is higher, plus over 80 or over 85-year-olds. And so considering where in the spectrum we want to be, if we're thinking more upstream around advanced care planning versus downstream and advanced symptom management, there are wide arrays of where we could go from severity. And so there are questions here, a couple have raised around using the FAST scale and how do we measure some of this. And So that's kind of where I'm going to lead into around this severity piece. There is advanced dementia, which is with it, if you follow this continuum, kind of the late stage of severe dementia. Some places they put this outside of as past severe dementia. It's more a semantic than anything else. Folks with advanced dementia are, depending on the criteria, have substantial deficits related to function, ability to get out of bed, to converse, recognize people, speak. But it depends on the illness. And so there is still some squishiness here. It's not as tight as one might think it is from a field that one would think has been pretty firmly developed, but as you dig deeper is less so, especially in these advanced stages where neurologists typically had spent less of a focus. And so if we look at things like the FAAN scale, one of the big things that I think people don't recognize when we move into the staging and thinking about staging is that the FAAN scale is only for people with Alzheimer's disease. And since most of our patients do not have a definitive diagnosis of what type of Alzheimer's disease and related dementia they have, it can be very problematic to use the FAAN scale for staging because it doesn't equilibrate necessarily with the other forms of dementia. And so we really have to think through, if your inclusion criteria are only those with Alzheimer's disease, great, the FAAN scale is a pretty simple one to use. But if you're looking more from a overarching functional perspective, FAST is for Alzheimer's only. And if you're not specifying Alzheimer's disease, it really doesn't have the validity to be used. Another commonly used palliative care measure is the Palliative Performance Scale. The problem is it measures survival only, and that's at best. And it doesn't necessarily always link up with a lot of the symptoms that are being used, and is not used outside of the palliative care world. So if you're doing a ADRD related study and trying to use the PPS as your screening or recruitment criteria, a lot of questions may end up being raised in study sections because it's not a scale that has a ton of validity beyond survival-ish in this population, and it's not used a lot within the neurology field. And so that starts to run issues in depending on who is reviewing your grant. If we start to look more into the Alzheimer's realm, we run into things like the CDR. I know Laura Hansen has used, or I believe Laura Hansen has used CDR in some of her trials. One of the benefits of it is for academic research. It is free. It's copyrighted by Washington University in St. Louis. And it has what is essentially a 5-stage measure. And so that has some pros to it. It's a fairly simple rating scale. It's used a lot in dementia trials. There's a training that you can do for how to perform scoring, et cetera, but it's only 5 levels. And so depending on how finely you're trying to split the severity of dementia, it may not meet your needs, or it might. So it's something to think about in terms of that component. So it can be a good measure to use. It can also, it does have some limitations, however. On the flip side, you can use informant-driven scales. One is the Quick Dementia Rating Scale, which is developed by a colleague of mine who's a neurologist, Jim Galvin. It's informant-driven. It's newer, so it's less familiar, but it has good reliability and correlation with all of the other measures that we often hear about. So the CDR that I just showed you, as well as some of the other tests I'm going to talk about next. The nice thing about this is if you're focusing on caregivers, this function focuses a lot on functional status. and it's done by the caregiver. It's 2 pages. It doesn't take a ton of time to do. We actually use this in my R01 as our screening instrument for if they're eligible. And it's nice because it can be done over the phone. It can be done directly with the caregiver without having to involve the person living with dementia. Not talking about consent issues, just talking about administering the survey, because this goes to the informant. So there are some nice things about it, but again, is not technically an objective scale based on evaluating the person living with dementia. And so depending on where this is going into, you may run into some concerns around that. And then we have our other tests. And so what we've often seen a lot in the literature is the mini mental state exam, full steam mental state exam. You're supposed to pay $1 for every time you use it. It has issues around education and socioeconomic status and race that make it really not the best tool to use. And so I strongly recommend not using it and going for any number of other tests. The MOCA had become, over the last several years, our tool to go to. However, they are now requiring what I think is $150 certification for anyone who is going to use it. And so if anyone's read, I think it was Eric Whiteera who did a Jerry Powell blog post on this a couple of, maybe last year sometime when this started to come into effect, when they notified of this. A lot of people are moving towards the slums, which is at the bottom of the screen here. It looks very similar to the MOCA and the MMSE. However, it's also out of 30 points. They have different cut scores for high school education or not, which does take into account a lot of the sociodemographic factors that affect the MMSE. And it's VA copyrighted, which means there will never be a cost to it. And so it has a lot of benefits to it. Just to show you though, in between the two, I read it out, and the slums, which is on the bottom, there are a whole other list of battery. Different people like to use different ones for different reasons. The mini cog is only good at best as a short screener. It's going to cover anything related to delirium or dementia. So it's not going to be incredibly sensitive and specific. I wouldn't use it specifically for ruling patients in. If you're focusing on trying to keep people with cognitive impairment out, it may be okay. But there are a whole host of other tests here. In the end, you have to think about what am I trying to achieve here, and how focused am I trying to be related to diagnosis versus brief mental status tests. The other piece around this is you can't do cognitive testing technically when someone is in an unusual environment, when they have delirium. It's supposed to be meant more for when they're in their own environment. And so all of these tests do have some barriers if you're going to perform them in a hospital versus in either outpatient setting or where someone lives. So your mileage may vary on all of those things if you're thinking more hospital-based. And then we need to think about using past diagnosis of dementia, or trying to wait until they get out of the hospital. We can technically try and you can try and stage them or do some of these tests, but because disorientation is likely to be much greater in a person with dementia in the hospital setting, in the acute care setting, or having just been transferred to another setting, you're going to have some issues with reliability. That's one of the nice things about using an informant-driven mechanism, is you can ask them to think about before that hospital stay. So you have to really think intently about the design questions around these pieces and what's most important to you. So before I move on from type of patient and screening tests / staging tests, are there other questions that this set of slides has raised amongst people who are listening about how to, effectively use these things to consider your study population and how you would test that population for inclusion and exclusion? And I'll give people a minute to type in if they have questions. Okay, so I'm not seeing anything at the moment. So either I really lost you, I was really clear, or your keyboards aren't working. So we'll work on any of those three hypotheses for the moment. But if you have questions, please keep them coming as we go along, and I'll try and address them all as we move through. The next real big question that has to be answered is, what outcome measures am I going to use in this study? Because the outcome measures we traditionally tend to see in other settings, so the FAAC, the ESAS, are not really focused on this population and don't necessarily have validity in this population, much like the PPS has some very limited validity and reliability within this population. And so when it comes to outcome measures, we really, again, need to be quite intentful, because, and what we include as a primary measure versus a secondary measure as well, because movement and ability to affect one of these outcomes might be much greater than the other. And what is it that we're really looking to do in whatever our intervention is? So if we look at kind of one of the things we tend to use in palliative care, which is quality of life, there are some well-validated, or at least decently validated studies or instruments that can be used around quality of life for persons living with dementia specifically. So I'm using the QOL-AD in one of my studies. There's the EQ-5D, there's the DEM-QOL. They can be measured in both the patient and the proxy with modest correlation with each other. So sometimes it's interesting when you have the dyad to be collecting it in both of them. But it depends, again, where you are in your severity of illness. So people with severe and advanced dementia are probably not going to be able to answer any of these with a lot of reliability. And so then we're looking more early on, mild, maybe moderate dementia, and otherwise using proxy. These instruments do often include both function and symptoms. So the nice thing about it is it does give you a broad array of things to look at, and it can cut down on some of the other measures that you're collecting. So for instance, QOL-AD includes functional status, and therefore you don't need to separately collect functional status necessarily. The issue, though, is it can be hard to move the dial, so to speak. Quality of life is a really hard measure to move. And so you may end up being broken down into individual measures within the quality of life focus. And so then the question becomes, do you really care about overall quality of life? Are you focused on symptoms? Are you focused on functional capacity? And if that's the case, should you be doing an overarching scale, or should you be breaking it down and doing more known or more validated specific measures for symptoms, for function, et cetera? And so that's a key design question, and it may be an either or it may be both. I can tell you in one of my studies, we're measuring both quality of life and the component measures, because there are some slight variations in how they are collected, but we're not collecting them all at every visit. And so we're we're trying to look at it from a correlative perspective and seeing how much quality of life and behavioral symptoms and functional status interplay with each other. And so we have measures of both, but that's not necessarily the best, especially if you're worried about burden on participants. So if we're thinking about behavioral and psychological symptoms of dementia, which is our next focus, there are multiple different instruments. I think there was a systematic review that there are like 83 of them out there, and there's probably more than that. But really, when it comes down into the literature, a lot of the ones that used to be used are not being used as much. So I haven't included them here, like the BRSD from CIRAD, which is no longer like as heavily in use. Most Alzheimer's and related disorder studies have moved to using some derivative of the NPI. I use the NPI-Q, which measures the informant's view of whether there is one of, I think it's 15 different symptoms present, the severity of those symptoms, if they are present, and then the caregiver's distress related to that symptom. There's a nursing home version, there is a short version, there's the full NPI. They have pretty good psychometrics, and they're kind of the standard that's used at this moment. If you're just focused on a specific symptom, let's say agitation, then there are other, or depression, there are other symptoms you can look at. So the CMAI, which is the Cohen-Mansfield Agitation Index, is kind of what has been used a lot for agitation specifically. There is the Cornell scale for depression and dementia, which is depression specifically in moderate to severe dementia. So it really depends what you are trying to target as to what measure you would want to use. The broader you are, the less in-depth you're getting into each symptom. And so those are the things you want to think about. How in-depth do I want to focus on a specific symptom versus a focus on the larger overarching set of symptoms? The other thing to think about is, where is your patient in terms of their trajectory? If your subjects are going to be more mild, you may actually be able to ask more informant-driven questions. So you, for instance, the geriatric depression scale and the PHQ-9 are both still have validity in mild cases of dementia. So it's really thinking about your population and who are you focusing on. And if you're focusing on a broader population, do you have one set of instruments for mild and another for moderate and severe? Do you ask both sets of questions across all populations and then look to try and correlate them and then use one or the other? There isn't really a right answer. There are just lots of complex questions around design that you can go in any number of different ways. And you really need to think it through, because every additional measure is an additional chance to lose recruits or to lose through loss of enrollment over time. And so these are the things that you have to think about. How focused do you want to be? But with that focus, having shorter study visits and less burden versus collecting a panoply of measures, which may increase your ability to answer lots of different questions, but can mean that you're less likely to be able to recruit and retain. And so it is a balance of on the scientific side of recruitment and retention versus outcome measures. So that aside, in terms of symptom measures, a couple of other outcome measures to think about. There are some pragmatic symptom measures. There's the minimum data set, which is used in nursing homes. There's the OASIS, which is used in home health. There's the new hospice item set and the new OASIS, which will both be available probably sometime in 2022 to 2023, depending on how things go in the trial runs that are currently being set up. So there are a bunch of hospices beginning a demonstration process on a new minimum data set for hospice. And then there's EHR chart data. So beyond the unfortunate spelling error here where an E got cut out, the issue is that your mileage may vary with all of these. There's lots of issues in terms of garbage in, garbage out, who is taking this measurement, and how well do they actually cover it. So for instance, on OASIS, which is the home health data set, the PHQ-2 is pretty much a required element. However, if you look into the documented literature, one, PHQ-2 is not valid in persons living with dementia at any stage. You have to use the PHQ-9, even in mild dementia. And two, what we found is that home health nurses, who are the ones that primarily fill out the OASIS in about 99% of cases, actually many of them will skip over the PHQ-2 because they don't want to make their patients feel uncomfortable. And so if you look at the positive PHQ-2 scores in a set of OASIS data, it's going to be well underreporting. And if you look at the minimum data set, you're often going to find underreporting or lots of variability compared to what you're measuring. And so this comes out when you're trying to think of pragmatic trials. How are you going to measure these things? Same thing, EHR data, unfortunately, primarily in hospital, but also in primary care and outpatient settings, the data collection isn't really that much better. There are substantial weaknesses there. A lot of times what we end up thinking about in terms of pilots for pragmatic trials is to try and do some primary data collection and match that up with the pragmatic outcome measures that you're thinking about, so you can see how reliable those measures are versus a gold standard. And I'll show you an example of that we're actually doing in our R01 in a little bit. But these are things that you can think about which do reduce your burden on the patient. And then another outcome measure to think about, which may be pragmatic or may not, depending on how you design it, is goal concordance. And so we have a lot of studies in palliative care that focus on advanced care planning, on surrogate decision-making, on goal concordance between what the patient wishes for and the care they get. So this is another really important issue. It's one where we also really need to think about whose goals we are looking at. And so are those goals the person living with dementia goal? We know that those individuals, if they're more mild phase, can still answer many of the questions around the type of care that they want. They may not be able to weigh in very complex situations if they have, depending on their executive function ability and their short-term memory and retention skills. But they can weigh and balance a lot of things. They can certainly designate healthcare proxies. They can have conversations. But once you get into moderate and severe, that becomes harder to do, other than there is evidence that in moderate dementia, they can still designate a healthcare proxy in most cases. And so whose goals are we looking at? Are we looking at the person living with dementia? Are we looking at the caregiver? Are we measuring from ACP documents? Are we measuring treatment intensity? What is it that are our measures here? Are we doing a ACP session and then following up longitudinally in a very long study, right? How are we designing to measure this? So it is possible to do that. It will also, in the next couple of years, be possible to do some of this pragmatically. Many states have developed POLST or MOLST or EMOLST or MOST or whatever acronym your state is using, databases, and those can be measured electronically if you gain access to those databases. So there is a pragmatic outcome measure there to think about. So these are all good things to think about as you're trying to design. If your goal is around goals of care and advanced care planning types of issues. The big question is, who is that the goal of, and are you actually getting the patient's goal when you're asking the caregiver for their opinion? This is an issue throughout palliative care, not just for persons living with dementia. And then a couple more outcome measures just to think about: caregiver symptoms and health. So if we're focusing on caregivers, there's a multitude of measures focused on strain, burden, their health, their function. So I'd say the 100-pound gorilla in the room for this, or 1,000-pound gorilla in the room for this is probably the Zarit burden inventory. But there are other measures, the modified caregiver strain index. You can use items like the SF36 or 12. You can try and use promise measures. There are a multitude of different measures that you can choose, but if you are looking at caregivers, you do need to think about caregiver health as part of that process. It has a significant and direct effect on a burden as well. I'm going to come back to some other things to think about in relationship to all of this, and again, when we're thinking about designing our collection of other variables. One of the problems with caregiver symptoms and measuring caregiver health is that pragmatic measures are likely not available in most cases unless that caregiver is within the same health system as the person living with dementia, and you have their permission or you have a waiver to collect their data as well. And so that becomes more challenging. Within Impact Collaboratory, there is a PCRO core, patient-centered reported outcomes, which includes things around caregivers that I believe Christine Ritchie is on and Laura Hansen is the lead. We also, within the PCRC, have our caregiving core that Betty Farrell and Nick Dion Odom are the lead and the co-lead on. And so maybe places to think about both from a pragmatic, but also from a non-pragmatic standpoint, and design questions a place where you can go. Some other outcome measure around utilization may also be hard to collect or move, depending on the patient population that you're choosing and what your intervention is. You can collect patient and proxy collected resource utilization. There is the RUD, which is used in a lot of Alzheimer's disease trials, which has been shown to work. It is an informant collected measure around primary care use of various disciplines in the outpatient setting, emergency room visits and hospitalizations. It's not going to be as strong as using administrative data because it's based on recall, but it is a strong option. Pragmatic data collection is another way to go, either using EHR data or CMS data. There are blind spots in both of these without getting too far into this. One thing around EHR data is that if someone goes outside of your system, let's say, then you're not able to collect that data as well unless you also have permission to use the health exchange, and that becomes its own larger issue. Same thing, CMS is only going to give you data in older adults, and so if you're trying to collect caregiver data, you're not going to be able to do that if the caregiver is an adult child. As an example, you used to also be limited by people who are in Medicare Advantage not being able to collect that data. We now can collect that data from CMS. So that's another thing to consider. There was one question going back, sorry, to caregiver health and thinking beyond self-rated health. How do we measure this? There are, in terms of measures of caregiver health, you can, for instance, use, if the caregiver is an older adult themselves, you can go into claims data and use claims data. You can look at measures of function beyond self-rated health. So you could do a Karnofsky or a Australian Karnofsky or a Barthel index or any of the other function measures that can also be used. You can also think about asking questions around chronic conditions. And so there is a verbal version of the Charlson Comorbidity Index that you can use, for instance, to collect what comorbidities individuals have. You can also try and collect data from the EHR, though that's only if they are within the health system or within CMS data, and so those can be messier. So those are some of the things we've seen collected in caregiving. I'll show you what we're collecting in our study as an example of some of those things in a minute. The other question is, do you want to use mixed methods? And so a lot of studies in palliative care, where you're moving kind of into this implementing interventions phase, may strongly benefit from mixed methods. And so can you add a qualitative, which is a little bit different than mixed methods altogether, or a mixed methods component, exploring attitudes, beliefs, experiences in a subset of subjects? And then if you do, can you converge that with their quantitative data? That's when it becomes a mixed method study versus just a side-by-side qualitative and quantitative arms. I'd say many reviewers now will criticize you if you collect qualitative and quantitative data and do not use a mixed methods design. And so I'd really come back to how you're going to do this. And if you are you doing it in a full-scale clinical trial? Are you doing it in a stage 2 or 3 trial, stage 1 or 2 trial before you hit a stage 3 or 4 clinical trial? There are different ways you can do it, and it depends on what you're trying to target for that qualitative information. But it can add a wealth of additional richness to the data, but it may be hard to recruit for that sub-study, and it adds extra dollars and time. And how do you meaningfully include persons living with dementia in qualitative studies, in qualitative components? It can be done in some cases, but it does depend on the stage. Certainly with caregivers, it can be done, not easily, but can be done, but you end up having to think about, if you're separating a caregiver, who's caring for the person living with dementia? And so something to think about. So that's measures. Moving into inclusion and exclusion criteria, which is one of the last kind of key focuses here. This population is notoriously hard to recruit. And so the right target at the right time needs to be considered. So are we being more pragmatic or less? Are we choosing a specific type of ADRD or not? Are we choosing a specific stage of illness or not? Are we excluding or retaining certain comorbidities because it relates to the intervention? Are we excluding certain languages, because that's going to affect the diversity of our population? So can we include intervention in materials and consent process and instrumentation that allow for inclusion of diverse populations? Can we purposefully select can we purposely select a diverse sample through selecting the right sites? And so that's a key component here, where a lot of our palliative care studies are not in diverse populations. And there are huge factors across settings around diverse populations in both pragmatic and non-pragmatic trials that really need to be addressed and need our focus. And I would encourage all of you, to the best of your ability, to include sites that have diverse populations built in. So if you're in a city or state that has less diverse populations, trying to find other places that can serve as other sites that can augment that with other, to increase your diversity of population, and diversity being used broadly here, is really, really important because the disparities are substantial in persons living with dementia. And so if we look at this, there are disparities around diagnosis, there are disparities around treatment, there are disparities around institution. There are also sex and gender issues related to persons living with dementia and caregivers. And so if you design a trial for NIH or PCORI and you don't include those as part of your study design, you're going to get bounced out. It is now being, thankfully, I've seen study sections in general weighing these things more heavily than in prior iterations over the last few years. And then the other thing related to population diversity comes back to the measures that you can include. So including questions on sex and gender identity, for instance, and on social determinants of health, not just leaving it at the NIH kind of quote unquote required race and ethnicity and sex, from a male, female, but thinking about gender and sexual identity as well, are questions that we should really start to build into our studies. And there is some good best practice language around that has started to be developed, and I have it in my study as well, so people are welcome to ask about that. And so the last thing, I already talked about this first bullet point here, but making sure if you are going to try and target staff, try and target individuals that are from diverse populations, how you consider your intervention and multilingual staff are two key components here, and the consenting process and these sorts of things. They all have to be considered at the outset because there are costs associated with all of those things. And then in terms of protocol flexibility, when we think of recruitment and retention, how many visits and time points are we going to use? The more visits, the more time points, the longer those visits are, the less likely we are to recruit and retain. And then what happens with missed visits and time points? We do have this thing called imputation that we can use now if your study is big enough, which is great. We can also have flexibility depending on how you're measuring with some of those time points. And so for instance, in my R01 study, we have 4 visits over 60 days. Visits 2 and 3, we are allowed to collect over the phone. And that was actually a mid-trial switch to increase retention, because we were finding a number of subjects were going back into the hospital, or caregivers couldn't coordinate being at home with the person living with dementia at the same time when our research staff could come to visit them. And we didn't want to disenroll them from the study for missing an interim visit. And so the other piece that goes along with that is, when is your study staff available to do those visits? A lot of caregivers are only available in the evenings. And so how do you flex your study staff to meet with that? And then how do we make it easier to participate? And I think this goes for all palliative care studies in general, but particularly in this population. The caregivers are incredibly overwhelmed. And so the easier it is to participate, including incentives as well, telephonic-based, video-based, going into people's homes are all good potential options. Having time points that, while they might be fixed, it's plus or minus 3 or 5 days, depending on what your intervention is and how specific you need to be, thinking through those flexibility elements. And then issues around recruitment is that in general it's hard. It's harder in this population. And then you have assent and consent issues in addition to burden. We're using this 3-item questionnaire in our capacity assessment. We've trained and checked off all of our research coordinators across sites to ask these 3 questions around the purpose of the study and the risks. I can't remember the third question off the top of my head at the moment. But they have to answer and have a certain point total from those answers to be determined to have capacity to consent. If they don't have capacity, we attempt to assent them. If they don't assent, we don't do the study. If they can't even consent because they're nonverbal or they don't understand even an assent, we can still perform it. But you know, if person living with dementia turns us away, then we only complete the caregiver portion of the interview. And so you have to think about what's important for the person living with dementia to complete versus the caregiver, and that's going to depend on your milieu. The other thing to think about with this is, when does consent have to be performed? Because the caregiver may not be the surrogate decision maker, and so you may need to obtain either a temporary or full waiver of written authorization and consent and have only a telephonic consent, or a telephonic initial consent with the surrogate decision maker, and then have to receive the written one by email or by fax or in person within 14 days. There are different ways to go about it, but these are things you have to work through with your IRB and what they're going to be willing to allow you to do. So in our last 3 minutes, I'll open it up to questions, and I'm just going to breeze quickly through an example while people are asking questions. So we have a current R1 that's a stage 3, stage 4 hybrid efficacy effectiveness trial, where we are using a complex intervention to train and sustain a comprehensive compassionate dementia symptom management at home through home health clinicians. And so it's a pragmatic intervention, but we are collecting data both from the home health agency in terms of EHR and OASIS data, and also collecting our own gold standard data in the home. It's a stratified, clustered, randomized trial in 3 agencies, 20 care teams. The agencies are diverse. So our first agency has a large African-American population and Medicaid population that's in urban areas, as well as suburban and some rural. Our second agency has a large rural population, as well as some urban and suburban, but limited diversity. And our third is smaller, but has a large Latinx population. And so we purposefully chose those agencies because of what their populations looked like as part of that. When you look at our outcome variables, and this is all in clinicaltrials.gov, by the way, and we'll also be sharing the slides, we're using the NPI-Q for our behavioral symptoms. We have the QOL-ID as our quality of life measure. We're collecting both the brief pain inventory and the pain ad, so that we can collect measures of self-report plus non-self-report. We've got patient satisfaction, medication use, but then we have a bunch of caregiver outcomes around quality of life, burden, health, depression, and resource utilization. And we include literacy, religion, language, sex and gender, as well as education. And then we have some other supports that we're measuring. And so it's pragmatic in design. We're collecting both data from the agency's EHR plus our own. We're going to measure them against each other. That's a bunch of papers and interest of itself. And we have had to progressively become more flexible, because we found that our initial intake process, and I know we're running up on 2 o'clock, so I'll stop in a second. Our intake process initially had clinicians referring to us because we were trying to maintain the greatest autonomy for potential subjects. So the clinician had to ask if they were interested and then submit a short referral form to us. Let me show you the outcome of that. Here is our cumulative enrollment in orange, our monthly goal in gray, and our monthly enrollment in blue. As you can see, our enrollment was incredibly low. And so we had to move to an automated method of getting referrals sent to us based on ICD-10 codes. And we've now seen our cumulative goal narrow significantly compared with our target. And so you really have to think about how you're going to get referrals and recruitment and what's going to work. And we thought providing as much autonomy as possible was the way to go. In the end, it turned out that we needed to focus on what was feasible, and what our DSMB recommended to us was just automating the process and getting clinicians out of the picture, which I think is a lot of what we do in the hospital setting, where an outpatient setting where we just screen at the beginning of the day and have RCs going in. And so that's essentially the analogous process we're going through now, and it has helped us tremendously. With that, I'll answer kind of the two last questions that I have up here. One is on assent. Assent is getting the person's permission to perform whatever study procedures you're going to perform, even though they don't have the capacity to consent. Some IRBs require you to have a signed assent form. Ours is one of them, others do not. The assent forms are much simpler language. They can also just be a verbal assent if the patient can't sign things anymore. But it's essentially that they're saying, yes, it's okay to ask me these questions or do this procedure, but consent still has to be obtained by the person who can legally provide it. So if a patient says, no, I don't want this, even though they don't have capacity to consent, they are not assenting. So even if their surrogate decision maker consents, if the person living with dementia does not, then we don't enroll them in the study. And that's what assent is and how we go about trying to collect it. In advanced dementia, we may not be able to collect assent because they're nonverbal. They're not able to give us enough of an indicator that they can assent. We are allowed to not do assent in those cases. So it depends on how you do it. And then the last question was on appropriate size and scale of a pilot pragmatic trial to train clinicians to implement an intervention for caregivers. It really depends on what the goal of your pilot pragmatic trial is. Pilot trials in general, whether pragmatic or otherwise, are generally not powered to gain efficacy. They're more to look at a signal, to trial feasibility and acceptability and methods, to make sure that you have stakeholder alignment. There are, while there's not much in the literature at the moment, there will be a lot more coming out in the next 6 months on this topic, but I'd say the appropriate size scale relates to what your goals are for a pragmatic trial. So if you're trying to train clinicians, it might be scaled up to make sure that it's feasible and acceptable and usable by those clinicians. It may be that you are trying to get data that the clinician's knowledge and confidence change, in which case you're powering based on that, but you're likely not going to be powering for the caregiver. And so those are some of the things to think about. I'm happy to discuss that more offline as it's a much bigger question. Thank you for those that have stayed with us. I'm sorry we've gone a few minutes over, and thank you to PCRC for allowing me to present this topic today.
Thank you, Ab, for an incredibly informative webinar. We really appreciate it, and I'm going to turn this over to Naomi Gallopin, who will give us our final announcements.
Thank you, and thank you to everyone who's joined. Thank you again, Dr. Brody, for speaking. If all of our attendees do go to our website, we have 2 more webinars that are posted for the near future, one of which will be Dr. Karen Kale's part 2 on the NIH grants process. We hope that you join us for those as well. We'll also be sending out an evaluation where we gather other topics that you might be interested in, so please take a moment to fill that out. Thank you again to our speaker and to all of our attendees for attending. Take care, everyone.
And Naomi, if I did not answer people's questions online, please feel free to email me at ab.brody@nyu.edu, and I'll be happy to answer those questions that were asked.
Excellent. Thank you so much, everyone.